Good afternoon, everyone, and welcome to the Be Well Texas Behavioral Health Echo. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating today's session. Before we get started, please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. These sessions are enabled for live closed captioning. If you'd like to, sorry about that. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on the three dots or more menu at the bottom right of your Zoom screen to find that. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Be Well Texas providers, please make sure that you identify yourselves during this session by entering your information into the chat, or if you're joining via phone, please email your phone number and name to bewelltx@utisca.edu. We appreciate your support in helping us fully capture this record. We encourage everyone to join by video, especially for the discussion portion in the latter half of the session. That said, regardless of how you've shown up today, we are just happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6. You can also use the emotions menu in the bottom right of your Zoom screen to raise your hand and indicate that you have a comment to share. There are a lot of us in this space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or the discussions. Towards the end of the session, our wonderful Echo ID support, Kato, will be sending out a link to an evaluation survey. Please fill it out to give us feedback on how to refine and shape these sessions to address your priorities. And also, it allows you to access free continuing education credits. And all participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on identification of risky substance use, evidence-based screening tools, and will be presented by Dr. Katherine Dondanville. Following that, we will discuss a case presented by Melissa Nissen-Reno. So we'll start with some introductions, followed by didactics, Be Well program announcements, case presentation, and open discussion. Thank you all again for joining us today. These sessions are what we make of them, so I encourage you all to share your perspectives in today's conversation. And let's do some introductions right now. Dr. Aguilar.
Hello, everyone, and welcome. My name is Clarissa Aguilar. I am a licensed psychologist by discipline, and I'm the Director of Psychology and Training here at the Center for Healthcare Services, the local mental health authority for Bexar County, where we provide integrated health services for individuals with substance use disorder, severe mental illness, and chronic medical conditions. I also function as a behavioral health consultant in our integrated primary care clinics.
Thank you so much for joining us today. Katie. Katie?
Yep, my name is Katherine Dondanville. I'm a clinical psychologist at UT Health San Antonio, and my work focuses on helping get things like screening and interventions for PTSD and suicide into lots of different settings, like the settings that you all work in behavioral health and in communities. Thanks.
Thank you so much for joining us today. Melissa? Melissa, if you could please unmute and introduce yourself.
You, Melissa?
Yes.
Hi, my name is Melissa Nissen-Reno. I'm the Director of Outpatient Treatment, Recovery Support Services, and our new program, Learning to Thrive, at the Recovery Council of Southeast Texas. And I am also a LCDC.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am the program coordinator here at CSTAT. Welcome, everybody.
Thank you so much. Julie Parrish?
Hi, everyone. I'm the ECHO program manager here at CSTAT with Well, Texas. I'm also a rehab counselor and licensed chemical dependency counselor. Thanks for joining us.
Thank you so much. Jasmine Vidal?
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAT program coordinator. Thank you for joining us today.
Thank you so much. And with that, we will move on to our didactics. Kitty, you can take it away whenever you're ready.
All right, so let me get my screen up. So today we're going to focus on identification of risky substance use and substance use disorder, some of the evidence-based screening tools and assessments. We don't have any disclosures. And our learning objectives are to describe the benefits of the screening tools for patient care, identifying some different screening tools that might fit in your setting, and how to introduce them and discuss them with the patients that you serve. So we've got a poll that we're gonna launch, but I want to just make some space in that, you know, there are a lot of things that we are juggling as mental health providers, as administrators, as the different roles that we play. And so the poll hopefully has it launched.
I'm sorry,
Got the
Dr.
poll?
Dondanville. I cannot launch it. I'm
All
so
right,
sorry. Wait a second.
I figured it out. It's going. But I want to just get a snapshot for you all is that you work in a range of settings, and setting really matters when we think about what are we screening for, how, when. So the poll should have popped up on your screen. Did everybody see the poll?
No, I'm not sure.
Okay.
I see mine on my screen.
Okay.
Yeah, I see mine.
Great. So go ahead. What setting do you work in? In your setting, as part of your practice, you know, do you screen as indicated? Is every client screened like in an intake? What kind of screens? So we're just kind of getting a pulse of where things are at. Some of us may be in settings where we have really slick electronic screening that works really well. Most of us aren't. We got to print everything. And there's a lot of challenges related to priorities, having time to screen, clients' kind of openness to filling out questions, the electronicness, like sometimes we don't even have printers, right? Or we got a printer that's broken and that keeps us from being able to do things. So we want to just think a little bit about that. So I want to kind of come to this idea of, and I joke with the clients that I see, is that contrary to popular belief, us mental health providers, we cannot read minds. But sometimes that becomes something that is, you know, a challenge. And so, you know, without having objective data, there might lead to some negative consequences because we're not mind readers. We may miss cases. We may also have some stigma in that, you know, if we're only asking certain clients questions about alcohol and drug use, and we're not asking other clients, we're perpetuating that stigma at the client level. But also, if we think about the amazing didactic last month, we have some bias of what we envision people with these problem areas to look like and not look like. And that can really impact identifying and delaying intervention. So we have a wide range. I'm going to share the results for everybody. You can see where your colleagues are. But delaying intervention can also lead to more problems in that person's life and their own health. The other thing without systematic screening is we're inconsistent in our practices. And we might be overlooking co-occurring problems that are key to the overall treatment plan and success for that client. Okay. All right. So we want to talk about screening tools and some of the benefits. And what I can see here is that, more than half of you all are already screening at intake. You are screening for alcohol and drugs, a smaller proportion screening for trauma and PTSD, that you're using some screeners that are standardized that we're going to talk about. It seems like we've got a split between paper and pencil and electronic. It's so nice to see those who responded that almost 90% have electronic. But there's a lot of challenges around time and clients' willingness, and then not sure where to get started. So let's talk about the benefits. So when we systematically screen, we're able to identify problem areas early. It's objective. So the way that screeners are written allows for us to have the question asked the same way. And we have research that shows that if somebody is above a certain threshold, it means something. And that's based on lots of people, not just how Katie interpreted that question, or as a client, or Katie as a therapist, how I ask the question. It allows for consistency and efficiency too. So just having time, saving time is something we're always looking for. And that's one of the things that can really help us to tailor treatment plans and offer options. It also helps us with resource allocation. And so we're all in situations and settings where there's a lot of demand, and we have to determine what services and clients for what patients, and what is the best way to deliver stepped care as it relates to supporting the clients that we serve. It also allows us to tailor interventions. And one of the things that I know we all value as mental health clinicians is really being client-centered and person-centered. And if we're not gathering data on our clients in an objective, systematic way, that actually hinders us from being able to be client-centered and tailoring to the client-specific presentation. It also reduces stigma. So just like when I go into my primary care appointment, they take my blood pressure no matter what. That has nothing to do with whether I have high blood pressure or whether I'm at risk for high blood pressure. So it has to do with a standard procedure. And so that reduces stigma and allows for us to intervene early. So some of the key considerations are what setting you're in. And as we look at, for all of you, we've got a wide range from primary care, outpatient behavioral health, outpatient substance abuse, intensive or inpatient. The setting really matters. We also want to think about screening, which is identifying a possible problem, assessment, which is a more detailed assessment and possibly leading to a diagnosis, versus monitoring. So monitoring is something when we are moving forward in a treatment plan, we need to be able to monitor that progress. So the questions we ask are going to be different. In screening, we might ask in the last year or in your lifetime. But if I was asking that every week, I'm not going to be able to show any change. I'm not going to be able to monitor progress. And then method, like how are we delivering what options do we have? So one of the things that can be a barrier or something that feels a little awkward at the beginning of using measures is introducing this to our clients. So some language I like to use is, as part of our work, I'm going to have you complete some screenings. This helps us work together and make a personalized plan for you. We're going to be revisiting these. So if you're new to adding screenings and you have an existing relationship with your client, you might say, as part of our practice, we're now starting to systematically do screenings. And I think that this is going to be really helpful to tailor our treatment plan and to monitor that progress. I don't know any client that would respond with, no, thank you. I don't want something specific to me. I would like it to be a cookie cutter, one size fits all, right? But I think this becomes kind of this push-pull. And so this type of language can be really helpful. All right. So what I've done here is I've got a couple slides that give us some different types of screeners and some recommendation, the setting and the population. Before we jump into this, I want to just ask you all and open it up in that many of you are using screening, and some of you have talked about this challenge of clients' willingness to complete that. So let's kind of make a little space to think about like how this language might be helpful and what are the different yeah buts that this language doesn't help with. Yeah, does anyone want to jump in and share? I think what are some of the clients?
Wagner, I'm at Volunteers of America in Fort Worth. And I guess part of the issues that our clients or that our counselors here have in getting our clients to share at screening time is because many of them are with the criminal justice system. So how much information are they wanting to share to provide us? What are we going to use it for? How much will their supervising officer find out? Sometimes they're concerned about sharing too much information. And so we have to discuss that. We have a little blurb, if you will, to try to help them feel more comfortable before we start asking the questions about. And sometimes we just, get right into it, and the person opens up tremendously because they finally have someone to hear. And so it depends on some of that, the fear of what their supervising officer is going to figure out.
Yeah. And what do you have to tell the supervisor? What's the answer to that question?
What we share is everything and anything that we share with the supervisor is stuff that the client is going to sign off on. And so they're always going to have read it ahead of time, or they're going to have heard it with us. So,
but if I fill out a screening measure that says that, I'm drinking, is that being shared? Are my responses?
It's not shared that way. The individual responses are not shared that way. If they are in our facility for substance use treatment and as part of the criminal justice system, it's because their supervising officer has already recognized that they have a substance use issue. And so these individual little issues are not going to be a problem for them. And so we try to give them that ease. And it's also the concern of if they relapse or if they start using during the time that they're here, what would we share?
Does that have to be shared?
Some of it is, depending on the contract. And so if they provide me with a positive UA for something, I will have to discuss that with the supervising officer. And then they have to go and meet with their officer to be retested.
Yeah.
And so those things concern them. But the initial screenings, sometimes it gives more information than that they've ever been willing to share. So we tell them it's not shared,
Yeah.
that information is not provided to the PO. The supervising officer is not provided. They don't get a copy of it or anything like that.
Okay.
Yeah.
So one of the things that's really important and we're talking about is informed consent, right? So, and I think that we need to upfront and revisit what are the limits of our confidentiality.
Mhm.
And so, like, I think that's a really important piece of this. You know, where does this go? How is it used? So it's used to make a personalized plan. It also is going to be something I put in your medical record, and it allows for let's say we work in a specialty care. It allows for your whole team to be on the same page, and then we don't have to ask the same questions over and over. Wouldn't that be nice? So part of that is just like thinking through, like, what is the frame? How is it going to be used? Anything we ask of clients, we should share back the results, because that's really important to help them actively engage in that treatment plan. Yeah, other people, the yeah buts.
I think so. I'm with probation, and we actually do our own screenings and stuff like that. And I think that even in our own treatment, there's every expectation that they will continue to use, you know, probably up to in the middle of their treatment, you know, obviously not just because they started treatment, they're suddenly going to stop using, right? So I think it's also, you know, letting them, kind of reassuring them that this screening is for your benefit, to provide you treatment and not to use against you. You know, almost all the probation departments in Texas are, you know, we're definitely moving to that reform of, like, you know, we just want to be able to provide those interventions that you need so that you can be successful, not just on probation, but just in life in general, you know, address any of those needs that you may have.
We're also connecting, we're talking about justice involved, but we're talking about stigma. And so part of where we can really combat stigma, if our colleagues here on this line in primary care, if every time we go into our appointments, just like we've got our blood pressure, is that there are some simple screenings that are asked to everybody, so that when we're asking these questions as we get to secondary, tertiary care, like, that it's not unique. This is what happens. Think about blood pressure. Every time someone takes your blood pressure, I was at the dentist and I got my blood pressure taken, but we don't think twice about that being stigmatizing, that they think I have high blood pressure, that I have a problem. It's just the things we do, right, in order to maintain our health and well-being. So here are some example screeners. We're going to give you an Excel file that's got more information and a link to them. But here are example screening tools for unhealthy alcohol use. So we've got the Audit C, that's I believe it's like 3 items. The NAAA has a single item. This is like a single item that you would orally ask a client. The Audit C can be done as a self-report. But we also have some additional screening items. What are the things that you all are using? Are there any questions that are coming up as you think about, you know, screening for unhealthy alcohol use? Yeah, Patricia?
Yeah. I'm coming at this from a bit of a different vantage point. I outreach to primary care physicians and primary care clinics, and the chief barrier, obstacle that I encounter is that there is a lack of awareness within the primary care provider community about what resources patients can be connected to address their alcohol substance abuse issues. Because that awareness education is lacking in primary care setting.
I'm not here very well.
They never
I'll
graduate
repeat that.
to screening. So
Yeah.
screening is super cursory, super surface level. It doesn't graduate to the level of what is an objective tool to actually done in this issue because they don't know where the pipelines of care are.
Okay. Patricia, you're breaking up, so I'm going to repeat what you said. Patricia, we can't quite hear you, but I'm going to repeat what you said. I think this is really important. Patricia was saying, and she works in primary care, and one of the things that becomes a barrier to screening is, well, but I don't know what to do if they say yes. So because this setting is unsure about where to send people, they are reticent to screen. So I think that that's a really important thing for us to acknowledge as one of those barriers. And we have to build connection from if we're going to screening for something and then what. And so I think this is where we serve as advocates to help build those bridges and build in that screening, because this is a very common story. And I share that when I go to my OBGYN, the nurse asks me every time walking to the office or to the exam room, they ask me a question. I can't exactly remember how she phrases it, but it has to do whether I feel physically safe in my home. It's about domestic violence. And each nurse that has asked me this question, you can just tell on their face that they're thinking, please don't say please don't say that you don't feel safe, because they don't know what to do, right? So they're following a procedure that has been mandated, but you can tell they don't know what to do. And so I think, building those bridges are really important. The other thing that can happen is people think to themselves, well, it's not a big problem in our community. You're not measuring it. So that can be a barrier too. We want to systematically measure. And so the recommendation is actually to screen everyone over the age of 12, including pregnant women, for this. Okay, so let's look at the drug use screening tools. These are some examples. You may be using different ones. But these are good examples that would give you a threshold of problematic drug use. So the DAST is widely used, the brief addiction monitor, screening to brief intervention, that's another example. Other thoughts or questions about that? Depending on your setting, right? Frequency. What I like about the DAST is it also talks about different other behaviors, not just usage. Thoughts or questions? What are you all using? Okay.
I don't know if I'm supposed to raise my hand or not, but basically we just ask them if they use illegal drugs. And it's just a standard question.
Yeah.
And that's what we do. And nobody checks yes.
Right. What does that
So,
mean? What's legal? What's illegal? Right?
yes.
Like, where does
So,
marijuana fall? What if I'm abusing prescriptions? Like, right?
We actually use a lot of standardized tools, and then also depending on what the patient's there for. I'm an internal medicine doctor and part of the Be Well program, obviously. And so we have both Be Well patients, and we have patients that are there for their, annual physical or whatever that they're there for if they have a cold. And we have paperwork that they fill out when they first get started. with us. A lot of times we don't ask, unless I ask during the appointment, you know, whether how much are they drinking? Are they drinking? Not drinking? And then with drugs, I never ask people whether they use marijuana. And I think I probably need to think about that some more. Simply because it seems like everybody uses marijuana. Right. It's a terrible thing for a physician to say, but there are a lot of people who use marijuana in my community, and it's almost like if they use marijuana, like you said, previous question, what am I going to do with that information?
What I like
so-
about the DAST is it is inclusive of marijuana. It's inclusive of, like, if I'm using prescriptions like outside of what I'm been asked to, and then it gives you a threshold of like problematic, right? Is it causing interference? Is it impacting their life? So, and I think if you're part of UT Health System, I've been working a lot with the Epic rollout that you could elect into these measures pretty easily. But people are putting in the chat just a number of different things that you're using. And I think it's wonderful, right? If you're using something that works in your setting, that's great. I kind of put together like, okay, there's so many options. Let's just look at a few and think about kind of how does that change by setting, if we're doing self-report, if we've got electronic. But it looks like a lot of people are using some really good things. I do want to cover a little bit, and people are putting in the chat some mental health screening tools. And I want to put out there just a plug in that. I know many of you are screening for depression and anxiety and adverse childhood experiences. I'd really recommend that you also consider screening for PTSD. We know trauma exposure is very common, and that PTSD may be something that our clients are suffering in a comorbid way, and to not include that in our treatment plan or conceptualization might lead to a client not being as successful, because one of the ways in which people might be coping with their PTSD or avoiding the avoidance symptoms might be through alcohol and drug use. I put Mental Health America up here because if you don't have an easy way to administer screening measures, their website has all these tools on there in English and Spanish, and clients can just do it on their phone right in front of you. So that's a kind of a quick way to access screening quickly. So I really want to just thank everybody in this. This is just beginning to open this conversation and think about kind of what this might look like. And I know we've got a case that we're going to be talking more about, and they'll be sending more information about just some recommendations. And I'm happy to answer follow-up questions as you're kind of thinking about some of the barriers in your setting.
Thank you so much, Katie, for this wonderful presentation. It was a great introduction to screening in the SUD space. We may have time for maybe a question or two before we move on to the next part of our session.
I have a question.
Yeah, go ahead.
We use a lot of standardized tools, and one question I guess I have is, in terms of the flow of the appointments, sometimes it just seems like the patients are taking forever filling out these standardized forms for everything from, you know, whether their medications have changed, whether they are having PTSD. We use a lot of these standardized screening tools, although I think we can improve on the drug and alcohol standardized tools. It takes them a long time. Can you comment on that? Have you thought about that very much? Because then, you know, they've spent all this time, and then that cuts into my time with the patient.
Yeah. So I think a couple things is one, we want to look at the total number, right? What is the appointment? What is the objective? And so, for example, that might allow us to switch from something like the PHQ 9 items to the PHQ 2, because I want to also screen for PTSD. So I think like as we look at the total, we look at the domains, there can be some decision points that allow us to kind of pivot and get more things, but less deep. The other thing to consider is, are there different entry points? So for example, in one clinic I work in, we have the initial entry point is with the social worker, and we have certain things that we ask, and then everybody goes on to a next appointment with a prescriber. And so we've kind of shifted some of those questions over there. So like thinking about what is the care, like how clients move through your system is really helpful to think about when to ask what. Because if a different setting, if a client is coming in and they're coming into detox, that's not the best time to ask about certain things, right? That's a waste of all of our time. It's going to be a wild answers that may or may not help us. So that's the other thing to consider is like, let's look at like what the patient life cycle is and try to sprinkle across.
I have a harder question, and that is, how do you get the patients to be honest? Or is there something you can say to kind of, as you're handing them these questions, either on an iPad or, on paper, what can you say to them that would encourage them to be honest? Because I can tell you right now that probably 75% of my patients don't answer the questions, any of the questions, honestly, because they don't want me to bring up their drinking, or me to bring up, that they might have a mental health concern, and they think that only bad people have that.
Yeah. So, I mean, I'll respond from my point of view. I think one is we have to explain why we're asking the questions, how informed consent, like how is it going to be used in their treatment plan. And I also think the more we systematically do this across settings, it is not as stigmatizing, right? And so part of our work is really making sure that we're tailoring any of our interventions to you. And so we're going to give you some questionnaires that really helps me to make sure I'm doing my best job to help you. And so I think, that what I would say is I come from a PTSD point of view. And when we give clients a life events checklist, I challenge all mental health clinicians to screen everyone from PTSD. They'll say, oh, wow, I didn't know this. I've been seeing them for 2 years. I'm like, of course you didn't know. They don't want to talk about it. But like just a piece of paper check marking it doesn't mean we're going to talk about it, but it gives, we see a lot of disclosure that happens. So
May
I think
I ask,
we do our best.
Katie, can I ask a question or make a comment? Can you hear me?
Yes, yes.
Yeah, this is for just building on what I'm hearing the internal medicine physician talk about, because I call on primary care doctors, or I outreach to primary care clinicians. One of the themes that seems to be recurring is sometimes there is a comfort level or lack thereof in that primary care space, believing that I might be the first person who my patient is disclosing this particular issue to, and getting the clinician comfortable with the idea that this icky thing that maybe you're not equipped to address in your clinic, you might be the first person who your patient discloses to by virtue of just asking the question. And again, it kind of takes me back to what I hear from a lot of my clients is they don't go there because they're not sure what pipeline. They know they can't address it in their own clinic, and they're not sure what pipeline to drop the patient into. So it's kind of like bringing the primary care team to a place of comfort with just the notion of disclosure. And you're going to get that information first, and being okay with that.
It's still true for them whether we ask the question or not, right? It's still their experience. I want to be mindful. I know we need to kind of switch gears to this case. So thank you all for just your engagement around this. We know this is a really important area with a lot of challenges.
Thank you so much, Katie, and thank you everybody for participating in the discussion. Please keep the questions coming. We have the chat open, so please keep posting your questions, and we can address them as we go along. Katie, if you could please bring up the announcements. Thank you so much. The Center for Substance Use Training and Telementoring provides high-quality education and best practices. For responding to substance use, CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.yudhiska.edu. Next slide. Join us for our second Texas session of the year on Wednesday, November 15th. To register, please visit texas.org/sessions. Next slide. Texas 2024 is officially open to sponsors and exhibitors. Texas Substance Use Symposium will be taking place on February 29th and March 1st in Austin. If you're interested in learning more how to be a sponsor or an exhibitor, please visit texas.org/sponsor Texas. Next slide. Please join us for our next ECHO session on November 17th with Katie. She'll be speaking about client engagement strategies. And with that, we will move on to our case. Melissa, please take it away when you're ready.
All right, thank you. Let me get my screen shared. Okay, so let's see here. So we have I work for Recovery Council of Southeast Texas, and we have outpatient for male and female, and we have intensive residential for male. So this is one of the ones that females that we've had in our outpatient treatment. She's a 27-year-old female, white female. She's heterosexual. I'm going to come back to the questions at the end, but this is her third time in outpatient treatment. She has also been to intensive residential treatment twice. She has an extensive history of relapse. She is an IV methamphetamine and heroin user. As far as her existing strengths and resources, she is enrolled in RSS, so she does get recovery support services. She's enrolled in outpatient treatment again. She does have knowledge about addiction, and she attends NA meetings 2 to 3 times a week. So the strategies that we have tried and how successful they've been, prior to this outpatient attempt, she had outpatient treatment twice and was unable to maintain her sobriety. She was referred to intensive residential treatment 2 times. She went and then left without successfully completing the program and relapsed after both times. So she is also enrolled in RSS. So her substance use history, as far as the stimulants, methamphetamine IV, first use was age 22, and it's been going since then. And then at age 25, she started using heroin IV, and she is a regular daily tobacco user. She has had substance use counseling, like I said, outpatient. This is her third time. She's had inpatient twice, but she has not finished. She does attend the NA meetings. Previously, she was on Suboxone, and she got off of that and is reporting that she would not like to get back onto that. She does have some mental health symptoms such as depression, mania, or bipolar, so major depressive disorder and then bipolar disorder. And her adverse childhood events, her ACE score, have her down as a 6. So her history of trauma, she did grow up in a household where substances were frequently used. She reports verbal, physical, and sexual abuse. She felt unloved as a child and did not have the basic necessary essentials growing up. And she presents with a history of intimate partner violence. Now, I do have a couple other notes I'm just going to throw in there that I didn't put on this, but her father actually overdosed and died last year from heroin. And then she moved into that house. So she's actually in that house. She has a boyfriend who is on parole, who has now moved into the house. She is unemployed, and he is the sole provider for her. And she is expecting a very large cash settlement from her grandfather's death in the very near future. So some of that is concerning. So back to the top, talking to her, she does not want to get back on Suboxone. She has an extensive history of relapse. Longest period of sobriety was 2.5 months. She is involved in outpatient RSS and mutual aid groups. And she's also being treated for her mental health. She's taking her medications, and, seeing a psychiatrist. So I guess my major question is, what other steps can we take to assist this individual to help her in her recovery?
Thank you so much, Melissa, for sharing the case. And I will open up the floor for any questions or comments.
I have a question. So she is coming back for treatment. Is that because of she's legally required to do that, or is it of her own initiative, or what are her goals?
Well, she does have, she is on probation. Yeah, that was on there, and I left that out. I don't know, I skipped over that, but yeah, she is on probation. Her goals, she says she wants to be sober. She wants to be done with all of it. And that's one of the reasons she doesn't want to get on Suboxone, is because she says, I just want to get off of everything. But apparently she's not been able to do that thus far, not for more than 2.5 months at a time.
Anything in particular that she doesn't like about Suboxone? Did she have a bad experience with it? Sometimes people, if they're using fentanyl or heroin or whatever, then they take Suboxone. It's a very unpleasant. Did she have an experience like that? Is that why she doesn't want to use it, or is there another reason?
She reported whenever she stopped it, the withdrawals were absolutely horrible. And so she didn't want to get, in her words, hooked on that and, need that. So she'd rather just be done with all of it. But with everything that we've tried, she can't get more than a little bit of time sober. And now she's got a big cash settlement coming up. So that's a scary situation. Yeah.
I have a comment. Can you hear me?
Yes, ma'am.
Okay. A lot of times with these MAT programs that are for maintenance and just go on for years, they just give the medicine and that's it. But the MAT program here where I work, they have a counselor that they see once a week, and they see their provider once every other week, and then they come up here to get their medicine. And we also have educational groups during the week. I guess the withdrawals from Suboxone are maybe kind of, I don't know, but the difference is it's not Suboxone, we use buprenorphine, is that it's a medicine that you take once or twice a day like your other medicines, and you're completely functional as a human being when you're on it. It's not like, it changes the person, like you're not fiending for it and you're not doing anything that's possible to go get your drugs. So maybe would she consider a taper, as well as seeing a counselor on a regular basis, as well as, because sometimes it's not just one thing. You need to go to all of the different things, like, such as the NA meetings and your counselor and your psychiatrist, and staying steady on your psych meds. So,
yeah. I mean, we've had conversations with her, and she's just very hard-headed about not wanting to be on any kind of medication-assisted treatment at this time. And she is doing all the other treatments, meeting with her psychiatrist and everything else. So,
Okay.
but thank you for that.
I see a comment here from Sandra. Maybe try methadone and education about the how and whys of mood treatments.
Mm-hmm. Yeah, we've suggested that to her also. She doesn't seem to want to get back on that either. And like I said, she is involved in recovery support services. She does meet with her her peer specialist on a, every other week just to kind of talk about things. So she does have education and everything about these programs. She just it's like she's got her hands tied, so we can't help her. She's not allowing it.
I wonder for her, like, what if she could wave a magic wand, right? What does she want? I know a lot about what she doesn't want, right? But what does she want?
A little solution focused brief therapy. Yeah. Right. So yeah, I mean, we've talked to her about her goals and everything. I mean, she wants to be free. That's one of the big ones. She doesn't want to end up in jail. And wants to have a good job, all these types of things, and we've asked her. So, if you were to wake up tomorrow and you have these things, what would it take for you to actually get there? What might have to change, or what might what can we start doing to get us on that path? And she just she hasn't had a long enough period of sobriety, I guess, to continue. Yeah.
I saw in her history, she reported childhood sexual abuse. She's reported domestic violence. I wonder, is there any connection with the experiences of trauma and the substance use as a way to escape and avoid those memories or symptoms or not feel?
I believe so, 100%. But yes, ma'am.
I wonder, one thing that may be helpful as it relates to kind of entering into that conversation could be screening for PTSD and thinking about like how these things might be connected. Because it sounds like the mental health treatment is really medication management for the bipolar, which is great, but that might allow you to consider kind of how these things are interconnected, and then what would be kind of a way to help her, right, get unstuck from that.
Thank you.
Yeah. Carrie?
I was going to say, when I was reading it, minus the opioids, because my person is meth, you were reading my person's information. Because we have a peer, I have a peer, and we say we because we're just a team. The counselor's always trying to, and I know her trauma plays a major factor in it. She's went to treatment, and she always leaves for a medical reason because she does have breathing issues. She finds that, no matter where we take her, she says, oh, I want this. And so her counselor is working more on the trauma side, but I know where she lives is part of the trauma for my person. And I thought about that in the situation where her dad overdosed. And so I've discussed with her sober living, maybe because she's on a HUD voucher because she's disabled. She does work part-time, using it to find another location. Not that she has to go into to get her out of that one place where a lot of her trauma took place. Unfortunately, at this point, my person is back incarcerated. She got a new charge, and I hate that for her, but I don't want to see your person get there. So I don't know if that's a suggestion, maybe, If she owns that house because it was their house, maybe go into sober living enough to get that stable foot and build that foundation again. You know what I mean? Because it's hard to give up the childhood home or whatnot, but then have a safe space away from to a safe place to work on the trauma if we're not wanting to go into treatment and what that might look like for her.
Yes, thank you.
I have a comment. I feel a lot of pain coming from and I mean, I can tell you really, you guys really care about her, and she's just not. Everything's right in front of her. She's the horse that's thirsty, but you can't make him drink. Yeah. And I think we all experience that to a certain extent because not all of our, in fact, a lot of our patients are going to sort of relapse and so forth. But what I always remember is that even patients who are non-compliant and they relapse and they come back, and they do better if they're in contact with a substance abuse treatment program, a mental health provider. So she's maintaining those contacts, and those are protective for her. I remember one of the cases that really sticks in my mind is a lady who had been to prison 9 times, and she was just as rough as you could possibly imagine. And she became sober, and it was just a matter. I honestly did not think that she was going to do well. I saw a very poor prognosis. I mean, she was the last person I'd expect to do. I hate to say that, but we're human. And she became sober, and she got a job, and she became a manager, and
yeah.
Part of it's timing. We're there, and then when they're ready, they're gonna reach for the help that they need. When they're not ready, we can't make them take it.
All right. Thank you. Yeah, we've supplied her well with Narcan, and her, family, friend, any of them, they have Narcan. So that's just we've had so many overdoses, it's been horrible. People have passed away. So we're just trying to make that not happen again. I know that's not within our control, but we're trying to utilize all the resources we can to prevent what we can.
I see a comment in the chat about grief counseling. Has she been offered that? Especially since she lost her parent to overdose.
We have talked to her about that. I mean, and she says that she mainly talks to her, I guess, psychiatrist about that type of stuff. But we also have the crisis center, and we've set her up with a few sessions with her, and they do, grief counseling.
In the interest of time, we'll have to move on to a summary of case. Dr. Aguilar, if you could please summarize the case and the recommendations that have come up in the discussion.
Sure. Thank you so much, Melissa, for this really nice case review and having us discuss these really important principles of recovery and healing together. One of the things that I think was a through thread through the discussion is, Dr. Dondanville presented on assessment and screening. And one of the recommendations that stood out to me is how we might be able, or you might be able to use screening for trauma as an intervention. Assessment is intervention. It's a way of laying the foundation to helping both her perhaps understand a connection or start to begin to make some connections that are more conscious. And then also laying the foundation for some of the treatment to specifically target trauma, potentially. I know that she is doing some CBT work, and potentially trying to get that trauma focused could be helpful. I mean, she may or may not be ready for that, but it does sound like that is another potential issue. The other threads coming through in the recommendations was trying to perhaps address some of the grief and the relational pieces, the loss of that relationship. And I think we all know, all of us here understand that connection is kind of the antidote for addiction, and therefore trying to help her navigate this loss, and then help you all also maintain and the endurance for staying connected to her. I mean, that's kind of another through theme, is that we really have to maintain our own endurance for being there, being ready, and being open for when she is there, ready and open. So I do think that that's another kind of key piece that came through. Thank you so much for bringing this to us and for showing your, kind of courage and dedication to her. I thought Dr. Luckner's observation was so poignant. We can see how much you care about her, and that's very clear. And so I hope that this has been helpful to you, seeking to understand her, and I think is kind of the key. And I feel like you all are really trying to do that. So I will wrap it up there. Thank you so much, Melissa.
Thank you. Glad to be here.
Thank you, Melissa, and thank you, Dr. Aguilar, for that summary. And thank you all for joining today's ECHO session. As a reminder, to earn CME credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the Beeville, Texas team at beeville.tx@utisco.edu. We look forward to seeing you at our next session, which will be on Friday, November 17th at 12 noon Central. Thank you and have a wonderful rest of your day. Bye-bye.